Hello everyone, I'm Dr. Juma Bishwas. Today I'm going to present one of the very important topic of antenatal care module, and the name is antepartum hemorrhage. And this is very important topic, and you will get at least one of the question from this topic. So before discussing this topic, I want to request you, please subscribe my channel, press the like button, and if you have any questions, you can ask me on the comment box. I'll be very happy to answer all of your queries. So let's start with antepartum hemorrhage. So by definition, any bleeding from or into genital tract occurring from 24 weeks of pregnancy and prior to birth of the baby, we define it as an antepartum hemorrhage. Overall incidence is 3 to 5%. And among the causes of APH, the most common cause is placental, that is either placenta previa or placental abruption. So when we define the severity of bleeding, based on amount of bleeding, we can actually classify them like spotting, minor, major, or massive hemorrhage. Spotting means if any staining, streaking, or any blood spotting on underwear or sanitary protection, we term it as in spotting. Less than 50 ml of blood loss, that is we term it as in minor. 50 to 1 liter blood loss with no sign of clinical shock, term it as in major. More than 1 liter and or sign of clinical shock, that is term it as a massive hemorrhage. So if any bleeding more than one episode, we can term it as a recurrent antepartum hemorrhage. Regarding risk factor in case of placental abruption, if any previous history, like one episode, chances about 4 to 4%, 2 or more episode, chances about 19 to 25%. Other than that, any history of preeclampsia, IUGR, non-vertex presentation, polyhydramnios, low BMI, pregnancy following artificial reproductive technique, intrauterine infection, PROM, abdominal trauma, smoking, drug misuse like cocaine or amphetamine misuse that can also increase the risk of abruption. Regarding the risk for placenta previa, any previous placenta previa also added some risk of placenta previa in subsequent pregnancy. Previous cesarean section also increased the risk. The number of cesarean section increases, the risk of placenta previa also increases. Other than that, any previous termination of pregnancy, multiparity, advanced maternal age, multiple pregnancy, smoking, any deficient endometrium due to history of uterine scar, endometritis, manual removal of placenta, curettage, submucous fibroid, assisted conception can also increase the risk of placenta previa. There is always a question like, can we actually prevent antepartum hemorrhage or can we prevent them? Answer is no. Because the 70% of the placental abruption can occur in low-risk pregnancy, we can just encourage them to prevent some modifiable risk factor like smoking and drug misuse. For the prevention of the hemorrhage in placenta previa, the good practice is just to tell them to avoid vaginal and rectal examination when we are known that they have the placenta previa, and we can also advise them to avoid any kind of sexual intercourse. Regarding complications, we can broadly divide it into maternal and fetal. So maternal complication like anemia, infection, maternal shock, renal tubular necrosis, consumption coagulopathy, PPH, prolonged hospital stay, psychological sequelae, and complication of blood transfusion. For fetus, there's a high risk of fetal hypoxia, IUGR, prematurity, and fetal death. So for management, we usually advise them if any amount of vaginal bleeding throughout the pregnancy, they needs to be reported. If APH is presenting in midwifery unit, GP or A&E, that should be assessed, that should be stabilized before we transfer them to a maternity triage, and so that they can perform emergency delivery. For clinical assessment, we need to take full history if mother is not compromised. But if the mother is compromised, we have to resuscitate first, and then we can ask the full history. We can do the examination like to assess the amount of bleeding and cause of bleeding. If you see their placenta is soft and non-tender, and on 20-week scan, there's a low-lying placenta. So mostly the cause is placenta previa. If the uterus is tense or woody hard, most likely the cause is abruption. We can do a gentle speculum examination to rule out the local cause of like any cause related to the cervix, or if it is associated with any cervical dilatation. Digital examination we shouldn't perform unless otherwise, like if it is excluded, the placenta previa is not there. For maternal investigation, only for minor hemorrhage, we can just do a full blood count and group and save. But if there is any massive or major hemorrhage, we have to do full blood count, coagulation screen, 4 units of cross-match blood, urea electrolyte, LFT. We need to do clay wire test if the mother is anti-rhesus negative. If the ultrasound scan is not performed before, then we can also arrange an ultrasound scan. Fetal investigations we can do if mother is stable or resuscitate, then we can check the fetal heart rate and we can monitor by fetal heart rate by CTG. If the viability is cannot be detected, then we can do a quick bedside scan to rule out the placenta, the fetal viability. So now the next question is that who actually need hospitalization? So if any spotting that's no longer bleed, then they can go home. But if any condition like heavier than like any bleeding heavier than spotting or there is an ongoing bleeding, they should remain in the hospital until the bleeding has stopped. If there is any risk of preterm labor, we can consider corticosteroid from 24 to 34 plus 6 weeks. If the woman present with spotting and mostly the lower genital tract bleeding, imminent delivery is very unlikely. So corticosteroid is not needed specifically for the spotting. Tocolytic should not be used in case of major FPAs if the woman is specifically unstable or any evidence of fetal compromise. For delivery and labor, so if the mother is stable but baby is dead, then we can continue vaginal delivery. If both are compromised or either of them are compromised, then we have to consider cesarean section. In case of unexplained FPH, delivery time and mode will depend upon the senior obstetrician review. Regarding interpartum monitoring, if only one episode of minor FPH, they can be monitored by intermittent auscultation. But any active vaginal bleeding or if woman is in preterm labor, which is complicated by major FPH or recurrent minor FPH or clinical suspicion of abruption or any minor FPH with evidence of placental insufficiency, they should be monitored by continuous CTG. Regarding mode of anesthesia, they can have the regional anesthesia unless there is any specific contraindication. If mother and fetus is compromised and cesarean section is required, GA is required to facilitate the control of maternal resuscitation and to expedite the delivery. And the consultant anesthetist should be there if the mother is compromised. For third stage of labor, AMTSL is strongly recommended because there is a high risk of PPH. Argometrine and oxytocin should be considered unless there's any history of hypertension. If the woman is rhesus negative, in any FPH, they should receive antenatal prophylactic anti-D. In case of recurrent FPH, in that situation, they should receive anti-D at least 6 weekly interval. After 20 weeks, we have to give them 500 international anti-D followed by additional anti-D if fetal-maternal hemorrhage is more than 4 ml. For massive hemorrhage, that should be a joint approach. So we have to involve the consultant obstetrician, anesthetist, hematologist, midwifery labor ward coordinator, laboratory staff, portering staff, and neonatologist. And this is the protocol we have to follow. Like we have to follow the ABCD protocol. Like we have to assess the airway and breathing. We have to give them high concentration of oxygen, like 10 to 15 liter per minute. We have to evaluate the circulation. We have to give 14 gauge IV cannula. We have to take 20 ml blood for blood test. And we need to cross-match at least 4 units of blood. D means that you have to assess the fetus and you have to decide on delivery. So this is a very nicely explained the management of any APH. So if there's only mild APH, like up to 100 ml without any sign of clinical shock, so you just need to open up one IV cannulas and common crystalloid fluids. But if any massive hemorrhage or clinical shock, then you have to go through the ABCD protocol, like assess the airway, breathing, circulation, oxygen mask at 10 to 15 liter per minute oxygen. And they need 2 IV access and they should be in left lateral position. We have to keep the patient warm by using appropriate available measure. We have to transfuse blood as soon as possible. Until the blood is available, we can infuse them 3.5 liter of warm crystalloid Hartmann solution, 2 liter, and where colloid 1 to 2 liter as rapidly as required. Best equipment available should be used to achieve rapid warm infusion of fluids. Special blood filter should not be used as they slow infusion. So regarding the fluid management, crystalloid we can consider 2 liter, colloid 1 to 2 liter. Blood we can give cross match, but if the cross match blood is not available and clinical situation is urgent, we can give uncross match group specific blood or O negative blood. And we can consider the use of red cell salvage if available. For fresh frozen plasma, so for fresh frozen plasma, we have to give 4 units of fresh frozen plasma for every 6 units of red blood cell, or PT or APTT are greater than 1.5 into mean control. We have to consider platelet concentrate if the platelet count is less than 50,000. We can consider cryoprecipitate if we see the fibrinogen is less than 1 gram per liter. So this is our targets we need to follow. Like we have to keep the hemoglobin more than 8 gram per DL, platelet count more than 75,000. PT and APTT should be less than 1.5 into mean control. And fibrinogen count should be more than 1 gram per liter. So that's all about antepartum hemorrhage. If you have any questions, you can also email me, or if you want to know much more about of any topic, you can ask me on the comment box. I will try to present that as well. Thank you.